Thank you. Good morning, everyone. My name is Kidiende Chong. I work for the Ministry of Health, the Republic of South Sudan. I'm the Director General for the International Health and Coordination, which in other words is partner coordination. And I have worked before for over 10 years with faith-based organizations, managing healthcare facilities, planning and monitoring the achievement of, the health outcomes among the displaced communities. You all know South Sudan had a long war of liberation, so that's the part before we became independent. Then from 2014, I joined the government, and I was from the start put into this directorate to specifically be responsible for the partnership in the health sector in the country, and that includes both the partnership with the development and multilateral and bilateral partners, mostly in healthcare investment through the donor funding, as well as partnership with the private sector. So I'm actually happy to be part of this panel and at least to deliberate and discuss how best we can invest and support a business case jointly. Thank you.
Go ahead, Ian. Thank you. Thank you very much.
Yeah, good morning. Nice to be here once again. So my background is I'm a medical doctor, born in Ireland, but then moved to Uganda over 30 years ago. Started in the faith-based sector. And interesting, in terms of investment, I think that's also a significant sector, because people do that, when they come and they build a hospital or something, they do it because they have passion for it. So started in the faith-based sector, and actually had to attract donor funding for a hospital there. And that donor funding has continued for over 30 years. So it's about 70% subsidized. Actually, one of the things I'd like to make the point is that if you manage to attract such funding and you can sustain it, it's still a sustainable model. I remember one donor saying, "But you're just building a dependency," and I'm like, "But these are villagers. Farm Access was talking about building a system." We're working with government, working with NHIS, working with Farm Access, which is backed by the Netherlands government. You can actually get something that is the best bang for the buck to bring healthcare to people who really can't afford the real costs of that healthcare. So that's was my first experience in the faith-based system, and then I went on, started a clinic. And then that clinic grew into a hospital and a bunch of clinics in Kampala. And that was completely commercially based. And I often think in terms of the commercial health system. Hello? Yeah. The commercial health facilities in East Africa, you get a hard. Nobody's giving you any money. You're getting no subsidies from anybody. Everybody thinks you're just there to profiteer, and sometimes people are just there trying to survive. But in that, as I built that hospital, and that it was a combination. It was International Hospital Kampala and international medical centers, and then an HMO called IAA Healthcare, and that ecosystem then attracted private equity. And then that private equity attracted a strategic investor. And although I'm still the a shareholder and board member and just stepped down as chairman, I'm happy to say that there's a sustainable, long-term strategic investor, actually from Mauritius, who's been brought into the picture, which is takes the financial burden off me, and then that has enabled me to also invest in a university, small university, and some other investments. So I don't think there's just one way of investing. Can be in different ways, and because I've been there so long, then I've been able to do different things.
Good morning, everyone. I am Dawit Mogas from Ethiopia. I serve as Secretary General of Ethiopian Healthcare Federation. And by profession, I started as an economist. But due to the loss of my mother, who was a nurse, I was gravitated to join this very humble profession of healthcare. I started my career as a lab technologist and then built all the way to MPH, and I'm doing my PhD now. And I started as a small laboratory, diagnostic lab, and now I am running a family-owned hospital with over 120 beds, named after my mother, called Sister Ecclesia Memorial Hospital. And now, recently, just before COVID, sometimes you have to be lucky when you go into your passion field. And right before the COVID hits the world, we invested in oxygen plants in Ethiopia. And we're running one of the biggest oxygen plants. And fortunately, or say unfortunately, the oxygen plant have been serving the country when it did most, and also, paid all the investment, supported the hospital, and now we're in the expansion program of the hospital. So this is my career. And why I like this profession so much, just like Dr. Ian said it. Once you go in here, you don't have to depend on donors' money or on external supports and so on. You have to go inside there, find your niche, fight, and fight again. And then you'll break the egg and come out victoriously. So the health sector is very dynamic. You can do a lot. It's not for profit. If you go into a health profession for profit, I tell you, you'll not be happy at the end of the day. You might as well invest that amount of money on some entertainment thing or in maybe a tourism, for that matter, and can get so much money. But the thing is, I always ask myself, whenever I go to bed, how many lives were saved because of this hospital, because of this oxygen plant, and because of this diagnostic lab. And that is my profit, I call it. Thank you very much.
Morning, everyone. My name is Samora Otieno. I lead on health at the British High Commission. By way of background, medical training, I've worked with government, non-government organizations. I've worked with faith-based, as well as a bit of the private sector, and with experience working in Kenya on health, public health generally, South Sudan, Daktari, and Somalia as well. So I'm very excited to be part of this panel this morning.
Good morning, everyone. I'm pleased to be the only female in this panel this morning, which is a good depiction of how private sector started in Africa, but it's no longer like this. I'm Jerry Gitau. I'm a medical doctor, public health specialist. This year, we'll be going back to Makerere University to celebrate 20 years with my colleagues when we graduated. I've worked in both public and private sector. In my career, started in the public sector, went to the private sector, worked at AMREF, the World Bank, which I was leading a program called Health in Africa Initiative, which I know is very close to the hearts of all the federations here. Nice to see Dawit and Ian and South Sudan. We were at the forefront of strengthening and ensuring that private health sector was embedded in national health systems. Kenya Healthcare Federation, Ethiopia Healthcare Federation, Uganda Healthcare Federation, and even the formation of the East Africa Healthcare Federation. So this convergence here that is happening today and that keeps happening in all the countries, I'm very proud to see this, and having the federations as part and parcel of the reforms and the changes that are happening in all our healthcare systems, especially in the region. Currently, I'm working with the President's Delivery Unit, the Office of the President of the Republic of Kenya. I'm a senior director there, and basically our role as the unit is to ensure that all the priority development projects for the government and for the president are delivered on time. So one of the pillars I oversee is the universal health coverage agenda, amongst other state departments. Thank you.
Good morning. My name is Masibo Sami. I think amongst the panelists, I'm probably the only one who is odd one out because I do not know what I do. Usually when you have a job description, especially in government, there's always the last line, any other assigned duties. Those are my main duties. So usually when there's something that no one knows how to do, that becomes my duty. But in a nutshell, I am the county director for Trans Nzoia County. I am in charge of human resource management and development, issues to do with budgeting, issues to do with health planning and health financing, and everything in between. So that's what I do. I'm also a consultant with the Open Fences team. I also consult with ITech, and I'm also involved in a lot of the NGO space with the AMPATH team. Thank you.
Thank you very much. Now, I've taken a step back because I want us to start slightly differently here. Can we vote? Our techie team, are we able to do a Menti voting exercise? There's a question that I want to pose to the audience. Sorry. Just to see whether, is that something we can do? You know, I'm speaking as a layperson. When it comes to technology, my interaction is limited to SMS and more recently WhatsApp. Outside that, you know, I start getting migraines and, you know, my toes start hurting and, you know, I can't sleep. So I guess what I really wanted to do is just kind of set the scene before I sit down with the panel, you know, to have this interesting conversation about public-private collaborations in healthcare. And one of the things that, you know, we consistently see is a lot of confusion, and there's lack of clarity around what exactly do we mean by PPPs, public-private partnerships, you know, engagement. There's a whole bunch of words that are thrown around. And so what I want us to do, since everybody here looks slightly more techno-savvy than I am, I want you to whip out your mobile phones. It doesn't have to be very expensive. It doesn't even have to be fancy. It just needs to have apps. That's it. You know, so, you know, the techno people, please feel included. This is a period of inclusion, not exclusion. Yeah? So just take out your phone and go to www.menti.com. Just do that for me. Please kindly indulge me. Just go to your web browser, go to www.menti.com, and then there's a code there which I'll read. Because I know your eyes may not be as good. Those who are following online as well, please feel free. Just go to www.menti.com, and then there should be an opportunity to enter a code. Can you see that? Can you see that? So I'll read the code a couple of times. The code is 15123750. I'll repeat. The code is 15123750. Just enter the code. Oh, the voting has already started. Okay. Just enter the code and just vote. There are 4 options there. You'll see the options there. Just key in your vote, and then you'll take it on from there. Again, I'll repeat the instructions once more. Go to www.menti.com. You will see a page where you can enter information. Enter the code 15123750. I'll repeat the code 15123750. And then vote. Okay? Anybody needs more time? So this is not, I'm in a country where elections are almost do or die. It's almost a do or die affair. Let me reassure you, this is not a do or die affair. So, the stakes are not that high here. This is purely for conversation purposes. Dr. Kedieng, Kenyans are preparing for elections, so things are a bit steamy here. So you might see a lot of excitement and a lot of talk when words like voting and elections come into play. So I'm just assuring the audience, the Kenyan part of the audience, that we're not campaigning. There's no campaigning here. It's just a simple vote. So I'm going to close the poll. I think most of us have voted, and we have a clear majority. So there's a fairly good chance if you haven't voted, your vote may not count. Which is one of the things that suck most about democracy, isn't it? It only works when you're voting without knowing the results. If you know the results, then it will not make a difference. So we have a clear winner. Yeah. So the question I posed was, the Kenyan Ministry of Health signed contracts with equipment manufacturers to provide medical equipment and supplies at a fixed annual fee. We call this MES. No, not MESS. It's MES. We call it MES, MES. Yeah? Managed Equipment Service. And, the whole idea is they provide equipment. So these are Philips, Belco, Mindray, GE, General Electric, those big boys. So they have this contract where they provide equipment to our hospitals, I think 94 or 96 hospitals or something like that, across the entire country under this type of arrangement. So aside from providing the equipment, they train the staff in certain areas on how to use the equipment and the supplies. So this is a 7-year contract that's been going on since, I think, 2015, 2016, and should be ending now or maybe in 1 more year, or it might be extended, I don't know. I'm just an academic. And so the question I was posing was, what type of PPP arrangement is this? And the first option was, is it a concession? Is it a concessionary arrangement? Is it a lease PPP model, equipment leasing PPP model? Is it build, operate, transfer PPP model? Or the last one was neither. It's not a PPP contract. Our clear majority says, which is 36. It's about 60% of the voters. So clearly we have a president. Yeah. The president here says that it's a lease. So we call it an equipment leasing PPP. All right. Now, sorry to break the hearts of the majority here, but it's actually not a PPP. So the correct answer is neither. All the options are wrong. It's not a PPP arrangement. Now, we'll come back to that conversation a bit later on, but I needed you to vote so that you can see how wrong you are. I don't derive any satisfaction from telling you you're wrong, but I'm hoping that it allows you to reflect that some of the conversations we are having are quite important. This is huge, because if you think something is a PPP and it's not a PPP, you could be taking the wrong path to developing the contract and getting it, executed. You could get it wrong all through the processes that you're doing. And so there's a lot of misinformation between what is a public procurement project and what is a PPP as stipulated in the PPP Act and implemented through the PPP process supported by Treasury. So we need to understand that. And towards the end of this conversation, Open Fences will be sharing what we call the popular version of the public-private partnership framework for Kenya, which we hope we can actually work with colleagues as well to develop for other countries on how to simplify some of these complexities. But enough about me. This is not about me. This is about the panel. So I'll go back and take my my seat. But again, just to remind you, you're all wrong, man. So we need to start learning what these things mean.
So thank you very much to the panel. Clearly, you can see that a lot of us really, really need to understand these partnership things a bit more, because we use these words, but we don't quite appreciate the complexities around what do these actually mean. And the thing is, we live in a country where the national government sets the policy scene, and then they provide the direction. And of course, they use government instruments like taxes, subsidies, and of course, policy to influence what happens in practice. So I'm going to start with the only lady in the panel, who I have to say was my boss at some point. A lot of these people have been my bosses at one point or another. Yeah, Dr. Gitau, just tell us from the president's mouth. There's no media here to misquote me. Yeah? Okay, so tell us from the presidential delivery unit perspective. Is there an appetite, is there an interest in supporting these types of investments, public-private collaborations and partnerships within the health space? Is that something that the presidency is thinking about?
Thank you very much, Frank, Professor Frank, for that. And I'll start, you've illustrated this example very, very well. And I don't think there's any other big thing in the conscience or within the knowledge of Kenyans as to how government has worked with the private sector to try and improve health outcomes for Kenyans. And this was done under the leadership of His Excellency, the President, Uhuru Kenyatta. So I think what I want to highlight, Frank, and we had this conversation when we were at the forefront of providing technical support to the government when it was thinking about how do they invest, how do they upgrade the equipment for the public sector. At that point in time was at the World Bank, and we did the feasibility studies, we did the costing, and we looked at all the models, we looked at the laws. Our PPP Act at that point in time really didn't, because health is always viewed as a social sector, so nobody looked at health as an area where really we should have laws and regulations to see how we can work and invest with the private sector. So it was very challenging. We looked at our Hire Purchase Act, which only looks at hire purchase for TVs, furniture, and other items. Of course, that was not going to work. So, and what it brings out, and where Frank has shown the public-private partnership framework, is that the health sector it's very diverse. The amount of partnerships with the private sector are very diverse. You have your brick and mortar, direct brick and mortar, very easy to do a partnership, build a hospital, operate and transfer to the government. You have your fluid MOUs with the private public sector, with FBOs. Farm Access has clearly demonstrated how they are working with the county government of Kisumu. And I know there are very, very many examples. So it was challenging, and we had to look at other countries. What have other countries done? Government is not a manufacturer of equipment. We know about the challenges of obsolete equipment. And so we looked at different countries. We looked at India. We looked at the UK. We looked at Turkey, and they used this model of managed equipment service. So we had to look at the laws in Kenya and see how do we support this partnership with the private sector within the laws that are there. And that is how MES was born. And using the Public Procurement Act, Public Financial Management Act, that is how the 5 companies that Frank has talked about came on board. And this was a first for Africa. Even within the bank, no other country had done this kind of transaction, this kind of investment, working at this scale, working closely with the private sector. And so, yes, those of us who are Kenyans here know that it's been plagued with a lot of controversies. We have county representation here, and I hope Trans Nzoia has agreed to take up the MES equipment. But most importantly, that shows the appetite. When this government came on board, this kind of investment in the private health sector, almost $500 million over the 10 years, and we are hoping that this can be continued within the next government, shows the kind of appetite that the government has to work with the private sector. I'll give you a snippet of how much money we have saved Kenyans from paying for very, very expensive diagnostic services, right from your MRI, CT scan, to renal dialysis, to ICU. Kenyans, in the last, since we operationalized MES in 2015 up to 2021, Kenyans have been saved 131 billion Kenya shillings. This is money that has stayed in Kenyan pockets. What does this mean? Part of this conference is talking about the ecosystem. So health does not exist in its own little cocoon. This money that has been saved can be invested in so many other things. Preventive health care for this family. They can eat better. They can invest in better schools for their children, better clothes, better shelter, so many other things. So when we think about this kind of collaboration, it's not just that we've put this equipment here. Yes, I can get an MRI scan at a much cheaper price. What does it mean for the entire health of this family or this person? The other thing, of course, you're asking about working with the private sector. Currently, Kenya is rolling out UHC, trying to ensure that all Kenyans have access to a basic benefit package. And of course, we know that the implementation of UHC has to happen in a stepwise fashion. It cannot happen at a go. But at the same time, there are those who contribute, those of us who are employed, and there are those who are subsidized, the poor. In Kenya, we have about 5 million households that are poor. And currently, we've started with covering 1 million households in this financial year. And these indigents, in as much as they are able to access services in the public sector through the county public health facilities, they are also able to access services in the private sector for those facilities that are empaneled by NHIF. NHIF is a government body, it is a parastatal, but it has been able to empanel private health sector through the leadership of Kenya Healthcare Federation to that as soon as making sure that these private health sector facilities comply with the regulations that are there in terms of quality of care and all other manner of regulations. Again, this is money that comes from our government coffers that goes to both public and private facilities for the health of the Kenyan. And then when we look at generally in terms of the private health sector engagement in Kenya across all sectors, Kenya Private Sector Alliance, KEPSA, is very, very deeply engaged with government and looking at all sectors of the economy. Early this week, we had a meeting with KEPSA, KHF was there, basically looking at how is government responding to private sector and enabling them to do business to serve Kenyans. So these are just a few examples of how invested the government is in working with the private sector.
Thank you very much, Dr. Njeri. I think that was fairly elaborate. You'll agree. I'm sure colleagues in the audience and online might have a few questions reflecting that. But let's come down to the ground, because we can make all this noise at Harambee House, the president's home, but we don't know what's happening on the ground. So I'm going to ask Dr. Masibo, who is a manager at the subnational level, at the county level, to just share his experiences about what is there anything you're doing towards creating an ecosystem that allows you as a county to co-invest or work with the private sector?
Thank you, Frank. Professor Frank is actually my lecturer. When you guys were voting, I was wishing you knew Frank, because you never get anything obvious with Frank. He'll call you at night and ask you, good morning. And when you say good morning, good night, it's evening, he'll tell you I'm in a different time zone. But back to his question, I think we need, first of all, to contextualize this thing, because in Kenya and regionally as well, the private sector is very significant. I think in Kenya it's close to 50% in terms of facility count. In Trans Nzoia, where I come from, it's more than 50%. But traditionally, we don't engage them, because there's a difference. When Open Fences actually came to try and be an honest broker between the private sector and the public sector, we realized that talking is not actually engaging, because we usually talk with the private sector, but we do not really engage. And for the men, if you want to know the difference between talking, you talk to your wives every day, but the day your wife tells you, we need to talk, this is different. So we are coming from, we were in a space where we were just talking, but not really engaging. And mostly it was the public sector playing big brother and trying to direct the private sector. So I think we have come a long way. And it's not just Trans Nzoia. I think we were involved with 3 other counties in the project. We had Kiambu, we had Kisumu, as well as Homa Bay. And one of the things we realized, actually 3 critical things we realized. Number one is that for all the challenges that are in the health sector, 90% of the solutions are within the ecosystem. Like just talking to each other will bring out the solutions, because when we were discussing with the private sector, you could realize and see that we don't usually have to go extra county or outside the county to get some of these solutions. I remember a very interesting discussion when we were in Trans Nzoia during our engagement with the private sector. One of the engagements is that the public sector has a lot of human resource in terms of surgeons and consultants. But interestingly, there's a lot, the surgical queues, waiting times for the surgeries are very long in the public sector. The reason being that we do not have enough theater space. I think for Trans Nzoia, we have only 2 reproductive health theaters, the entire county, and 2 main theaters, the entire county. Now, the opposite happens in the private sector. They have a lot of space, idle capacity, but they do not have the human resource. And one of the proposals from the private sector was, why don't you deploy? Because the reason the private sector has idle capacity is because of cost. People cannot afford the cost of surgery in the private sector. And one of the drivers of cost is actually the human resource in terms of the surgeon's fee. And there was an interesting proposal from the private sector. If government can release some of its idle staff to go and serve in the private sector while still on government payroll, because either way they are idle, and then subsidize the cost, because now they will not charge the surgeon's fee, and make it affordable then for the public to go to the private sector. So interesting solutions coming out of the discussions. The other thing I realized is, just based on the example I've given, is not all solutions are supposed to be funded in terms of dollars and cents. We can easily just orient our workings and make sure that that is done. Frank always says you can throw money at anything and it will work. Even the Bible says there's a time people wanted to reach heaven and they were building the Tower of Babel. And actually God was worried that they will do it. And he confused them and gave them different languages, but they were going to do it. So if you have money, you can do anything you want. But we live in an economic problem. In a world where there's a economic problem, there's always not money. But you can fund all these things. The major thing we need to look at is not what money we need, but what will that money do? Because all things that the money will do most of the time are available within our reach. So that's something else we were looking at. And then third, and very, very interesting, is that for the solutions that we could not generate within the ecosystem, then we were building investment cases for consideration by probable funders. So what Open Fences was doing was guiding the counties to craft viable investment cases that can then go to scale. I think we were impressed with Kisumu, which is looking in doing a blood bank kind of investment, just linking the blood donation ecosystem from the donor all the way to the recipient and everything in between. So counties, I think, have there's a lot going on in the counties in terms of engaging the private sector. For us in Trans Nzoia, I'll give a few examples. We really focused, not really we were looking at the very low-hanging fruits. One of the things we are looking at, for instance, is the public sector attracts the very poor in terms of patients. Most of the time we are dealing with waivers, people requesting for waivers. And after we began talking with the private sector, one of the things that is coming up is we are getting the poor getting access in the private sector. A recent example, just this morning, we were discussing with one of the facilities where there's a poor patient who cannot actually pay, has been certified by our social workers to be very poor. And so we are negotiating with the facility because after COVID, COVID came with its own advantages because we have a very huge oxygen plant. So we are negotiating with the facility to release the patient and claim oxygen in return. So some of these solutions are within us, and we can easily collaborate if we just talk and engage for real. So I think the counties, that's in a nutshell, that's what we are trying to do. Within the ecosystem, talk to each other, find out who can do what, and then enable them to do that instead of being adversaries and fragmented in the way we were discussing before. Thank you.
Thank you very much, Dr. Masibo. I think that was fairly elaborate, and it just takes me back to a couple of days ago, the SDG Partnership Platform, which is one of the title sponsors for the event, actually running something separate at Safari Park Hotel, which is basically, the UN Investment Fund. And one of the statements of there from the keynote speaker was Dr. James Mwangi, who is the CEO of Equity Bank. Equity Bank is one of our larger banks. He said something quite interesting. He said, and he was addressing this to Treasury and ministry officials. He was saying we need to start to move away from, expenditure investment to expenditure. You need budgeting for expenditure purposes. So you're spending, on budget on line items. So you do budgets that are based on line items, and then that's how you spend. So you need to move away from that to developing proper investment cases that actually show the full 360-degree picture, including what is the return per dollar. What does it mean if you move money from this to that service? Which is the best way of optimizing the resources? And I think what Dr. you've been saying, Dr. Masibo, is thinking about developing investment cases, but you're not just developing them as government, you're bringing the ecosystem together so that when you're looking at how much theater space you have and what the deficit is, you're counting the public and the private sector. So you're looking at the full envelope, in totality, as opposed to looking at it in a fragmented way. This is quite interesting from Kenya. I just want to bring in colleagues from South Sudan and Uganda and just get their view as well on what is happening. Ian, what's happening in Uganda? What type of formations are there? What type of public-private collaborations are you seeing? Just reflecting on this.
Okay, well, before I just talk about Uganda, let me just say that currently Uganda, we're the chair of the East Africa Healthcare Federation. We said we'll have a conference in September. We'd like some of you guys from Strathmore and so on to come and give your wisdom again. But what's interesting to me in the region is the learning that we have from each other. So I'm listening to the Kenyan experience and I'm learning. And I think, and you're saying, so what's our experience in Uganda? And I think that's the benefit of coming together, different. My colleague from Tanzania keeps asking, Nasir keeps asking, so how are we making any difference here, And it's true, coming to a conference, you listen, but, how does that translate into the issues that you're talking about in county level? And I'm impressed that from the President's office and from a policy decision, then it's cascaded down to, well, the leasing equipment, which I didn't quite pick up, but it has worked. You're saying it has worked at county level. It has saved money. Yeah?
I think it has worked, Ian, and just like any other, ambitious and new kind of path-breaking innovation, there have been challenges, including areas where it just never picked up because of infrastructure and other reasons. But like Dr. Gitau said, we've actually looked at the numbers and the amount of money saved by those services being here, as opposed to people flying out of the country to get them or moving across. It's billions. It's 100 and something billion. So sometimes we miss the benefits because I think we look at the bad things. So, but it has worked with challenges and potentially could be improved over time.
No, I mean, and I think it's important because when you look at that serious public-private partnership that was done in Lesotho with that Queen Mahoto Hospital, I'm not quite sure what the final verdict is at. I know that it said it soaked up between 30 and 50% of the whole health service budget. So, and that's a World Bank project. Probably you know all about that one.
Can I reflect on that, just to make this a bit of an interesting conversation? I've been fascinated by the Queen Mamohato Hospital PPP. For those in the audience who might not be familiar with this, but that was pretty much Africa's first hospital PPP. I stand corrected. Huge investment, supported by the World Bank, IFC, but all the hospital, I think, was set up by the Tsepong, which is a South African chain consortium. And there was a lot of debate, and one of the biggest challenges that came out of that was the fact that nearly, I think, a third of the health budget went to that one hospital.
It was 30 to 50%.
Yeah, depending on the year.
30%.
Yes, but some of the information, so it clearly had a major problem. And Ian, sorry to interrupt you, just to emphasize that the previous hospital that was there, the Queen, named after the Queen, used to consume about the same of the budget with fewer services. And so it's, without going back and actually looking at the budget before this hospital came, it becomes very easy to sell a negative narrative. But this is a country where a lot of people would go to that hospital for healthcare services. And so if you look at their previous budget, it was still within the same range. So that did not change. What changed is this hospital came about and provided services that were previously not there. And a good example is abortion services. Before the hospital came, there wasn't a gynecologist in the country. And so a lot of botched abortions, people would die, or they would go to Bloemfontein in South Africa to get this done. But when the hospital came, a new demand came about, and so demanded more money. So it's very easy to overlook that aspect and actually say, why are we spending too much money there? Yeah, because people are dying before. The service wasn't there. So there's quite a lot that is globally hidden in a lot of these conversations. But I think the point you're trying to make, Ian, and I stand corrected as well, and I'd like to to finish that as well, is some of these things need, you need to learn from mistakes that have happened in other places, because you need to keep improving on that, because it's not right for one hospital to consume so much money. So how do you correct that? Do you make the envelope bigger? Do you get more efficiencies and everything else? So back to you, Ian.
I just wanted to add to what Frank was saying. I think the other nuance that never came out is that this hospital, first, the size of Lesotho as a country, the population size, and this hospital was basically targeting literally the population. I can't remember the population size of Lesotho. So the way the hospital was set up, it was a huge referral hospital, PPP, serving a small population that was still absorbing the same amount of the budget. And there was a hub and spoke model, and there was a specialist training also of doctors attached to that. So a lot of times we forget, look at the nuances and the larger impact on the population when we focus a lot on I think what you rightly talked about, budgeting for line items and not looking at the picture. So yes, there are challenges, but there were also very many good benefits out of that hospital.
But I think that's a good study for Strathmore and their, because we want to know what the learning lessons are. Coming back to saying, looking at what we're doing in the region, what Kenya is doing, because Kenya is doing one thing and it's NHIF. Tanzania is doing something different. Uganda's trying to get something through. At the present time, Rwanda's doing something different. And if we look and we talk and we learn these lessons, this is what the most valuable thing can be from these kind of collaborations. I think also, Doctor, you said that, talking to each other. I think that, yeah, why don't we just sit down and talk to each other? And I don't mean we can talk within the private sector and we can talk within the public sector. But do we talk in the public and the private? Do we talk with the funder and because when you look at the problem with the private hospitals, you said some of the private hospital facilities are underutilized. Yeah? So they have the facility there, but they don't have the patients, essentially, because the patients can't afford to pay. Now, the public facilities have the patients. Maybe they don't, sometimes they don't have the facility, sometimes they do, but there's a problem here of them being able to pay. We need to find a model whereby if you have an interventional cardiology center in Uganda, actually we have one. We have the Cardiac Institute in Uganda, which was set up as a sort of quasi, it got its own budget. They call them a vote, okay? It got its own vote, but it was still a government thing. It got state-of-the-art equipment, all singing, all dancing. It wasn't on a leasing agreement, so I think they had a lot of issues. Now, I don't work there, but I do think they had a lot of issues on procurement of small things. So when they would need stents, when they would need these things, the process of procurement was very long, and so that really interfered with their operational capacity. But then also the numbers of people they were charging, so the numbers of people who would go was small. So if you were to bring, and some of those guys said to me, let's do interventional cardiology on the private hospital, and some private hospitals in Uganda are now setting up to do interventional cardiology. But the issue here is that although we've got 43 million people, and I'm sure we've got enough people who need stents and that kind of thing, but what is the ability to pay of all those people who need the intervention? And how are they going to then flow through the private hospitals? Or if they're going to the government place, which then has a poor procurement policy and isn't really doing this stuff. So, we need to get together and talk and say, how do we solve these problems? That's not happening in Uganda. There's a lot of lip service still being paid to public-private and all that. But I was just thinking of the characteristics of the countries. And Kenya is very business-focused. The politicians are business focused as well as the business are business focused. Okay, and then we've got whereas Uganda is kind of politically focused, and it comes to some extent because Kenya has a very, very big private sector. Okay, not only a health sector, but the business sector is very big and very powerful and a very big lobby. And as you mentioned earlier, the government sits up and takes notice of them. But the Uganda private sector is quite small and a bit too much dependent on government. Okay, and so therefore they're not really getting their own independent voice and being able to say, this is what we should be doing. And that flows right through to the medical sector as well. So it's a bit too politicized. And anyway, I'll not go into the characteristics of the other countries. Well, we had a good discussion last night, which was interesting with Danny from Rwanda. But Rwanda is more autocratic, okay? But things get done, so that it's developmentally orientated. So, when there's a program, it's going to be implemented. And that affects both the public and the private, as far as that's concerned. So I think this whole thing of really talking to each other, learning from what's going on, finding the best practice, and then talking to each other, and then bringing in someone who's actually doing something in Kenya that's working and saying, this could work in Uganda. I don't even want to talk. Well, I'll mention there's supposed to be one big public-private healthcare collaboration, and it has soaked up $370 million for one project. And it's supposed to be like a build, operate, handover and stuff like that. And it's just being totally financed by government. And you don't want to go there because it's too political as to what's going on there. And that's just, that's the sort of stuff that, it just makes you retreat and say, let me just do my own thing.
Thank you very much, Ian. Dr. Kadian, in addition to just giving us a snapshot of South Sudan, we still refer to South Sudan as the youngest nation, but I don't think you're that young anymore. I think you're almost going to high school now, yeah, by my estimate. So, just getting your reflection on how the private sector is, and I know it's just coming in now. Are there opportunities that you're seeing, and from your experience as the head of partnerships at the government, are there policy spaces and opportunities for public-private collaboration in South Sudan in healthcare?
Well, thank you, Frank. And allow me first to go back to this. I said yesterday, South Sudan, as you said, we still say we are young. Even if you are going to high school, you will still be young. I said yesterday we are learning. So we are also learning, but we are careful. So this was a very good example. And it demonstrates to me beyond doubt that at times the majority is wrong. And you can see here, the majority is wrong. We could see, I don't only look at 36, but I look at the 52. The 52 are all wrong. It's only 13 that got it right. So as we know, Kenya is going for elections. Please vote responsibly. Vote responsibly. As I mentioned earlier, I work with the faith base for long. And even in the Bible, if the majority cannot be wrong, they would have not crucified Jesus. It was the majority who said crucified him. For those who are Christians, at least you remember that. It was a majority decision. So please, I repeat, when you are making decisions, the others who just follow the majority, please take that advice. Now, let me come back to public-private partnership and what is happening in South Sudan. I can just first look at the terminology itself. Private, public, and whether there is partnership. So it's not automatic. And for us in South Sudan, or in the whole of Sudan, our vocabulary was very limited until we signed the comprehensive peace agreement between the rebels at that time who were fighting for the liberation and the government. And the word partnership became very common, and we started to have a good understanding of what it means. Otherwise, the model of partnership between the horse and a man was always, being demonstrated in our daily life. So when we come and talk of public-private partnership, it is key that we know what it means to have that partnership. In the context of South Sudan and partnership in health, public-private partnership in health, I can tell you it's almost non-existent. Simply because as we are there, we are still putting up the policy framework, the policy and the strategy framework to govern this. We also know that when we talk of private, we talk of private for profit and also private for not profit, like the faith-based. If we look at the whole cycle, whether it is private or public, they must ensure sustainability of what they are doing. And that drives us to the reality. I come from a country where we all believe that we have fought for this country. This country should provide the services. The basic is education, health, and the services to some must be free, which is an illusion. It can be free. Even if you don't pay for it, someone somewhere else pays for it. And if you don't, and if someone doesn't pay for it, it will not exist. So when we talk of the private, and sometimes with that misperception that the private are looking for money, we also forget that even the government, all right, also does investments and have money. Even the government, the public also looks for profit. There are services, there are actually institutions of the government that also invest for government to generate resources in order to fund the government. So coming back to what is happening, and my colleagues are here, in South Sudan, there is a good collaboration between the public sector and the public and the private sector. But it has not reached to that level we describe it in that context. I'm saying this knowing that it also has a lot of risk around it. And we also need to be very frank here. A disease that exists in all of us, which is a risk of, a lot of illegal payments. The private sector, honestly speaking, is very vulnerable, where systems and structures are not well established. South Sudan, we are still in the making. And as I said yesterday, we have learned a lot in the region. Some of those things we learned them in the region. And we have become very expert in doing them. They will not take us anywhere, So we could still see that the risk involved needs a lot of efforts, all right, to put things right in order to realize what we want. I want to say also, when you look at the private sector, is doing a lot of work. And honestly speaking, we are in a situation whereby our public services, there is limited trust, which is another element. And this is what drives, the investment itself. So the private sector in South Sudan is booming, and it's good for those who are here to get this. And here, there is one important thing. If you know that South Sudan has the opportunity, has the potential to invest, the government has now admitted the fact that for us to sustain the services, for us to ensure, of course, we also need to ensure financial protection when it comes to the users. The government has the will, has the commitment, but still we are not walking the talk. And that is very important. One good example that I can give you is, because going back to the topic, we are looking for opportunities of, a joint investment case. I can let all of us remember that some of the funding mechanisms we are very much driven by, like the Global Fund and the rest. We look at them, this is a donor money that is coming. But if you look at some of these are actually financing institutions, are financing agencies, like the Global Fund. In the Global Fund currently, there is a demand for co-financing for all the countries. Those that have been working with the Global Fund, they know this. There is a percentage of up to 15% of the government or the recipient country to contribute to what the Global Fund is investing on. To me, that is a joint investment. Apart from others, because that is requested as an additional investment, 15% additional. Otherwise, the public sector is still providing, the infrastructure, some of the equipments, much of the human resource and all this. However, looking at the public-private partnership, I see there are a lot of examples and models where the government can be brought gradually to invest seriously in public-private partnership.
Yeah, I like that. And actually, one of the conversations that was happening early in the week as well was on blended financing instruments as a way of de-risking markets to attract other investors, private sector investors as well. So I think for a country like South Sudan, in my view, and happy to continue some of these conversations, is how do you get the right type of investors who are willing, to put their money in some of the early promise projects or investments, and take a bit of a hit, or actually have blended finance instruments that actually allow them to lower the level of risk as they're going into these investments. Because I think it's very hard for a commercial lender, to take that kind of risk, giving you money to invest there. But the world is now changing, and people are realizing that impact financing, impact investment and blended financings can actually help some of these markets, catch on very fast. So I'm really looking forward to that. But I'd really like to hear from David, again, going to the ground, a real example of what. So this is a case of you not letting a good pandemic go to waste, isn't it? Yeah, I'm paraphrasing somebody, I can't remember who. But the pandemic favored you in a way, isn't it? I mean, it found you there with an oxygen plant, and this is actually an opportunity for you to partner with government and provide this type of support. So just take a minute and tell us, how did that work? How did you manage to get this mainstreamed and to support government through this private initiative of oxygen, the oxygen coming up? Did you partner with the government? Did you provide support for for public patients? Or is it that there's no mechanism in place that allowed that, and this was a lost opportunity for Ethiopia? Which one is it, and how did it work?
Okay, thank you, Professor Frank. PPP is very different in Ethiopia. I mean, the concept itself is a very new thing. It's only your scholar by the name Professor Kamarogo, who came to Ethiopia and introduced what PPP means to the private sector as well as to the public sector. And the thing is, I remember his quotation. He said, "The future is PPP and digital." He's been keeping saying this and saying this and saying this to both the public sector and the private sector. So the developmental partners like World Bank, USAID, and so on, they came together and they put us both the public sector and the private sector and start giving us lecture examples. And we were benchmarking the Kenyans, how you've promoted through this PPP and so on and so forth. So one thing that made things very difficult for PPP in Ethiopia is the first thing is the approach towards the private sector. The public sector thinks that the private sector is only there for profit. Nothing but profit, profit, profit. And we were pointing our fingers toward them saying that the public sector is only making things difficult, bureaucratic, inefficient, and wasteful. So these two ideas were, drifting us apart. And finally, we had to come down to a roundtable meeting and start supporting each other. So at the ministerial level, the minister, our minister, health minister, is very much in support of the private sector. She's also working in private sector as part-timer and so on. So now, the problem is when you go down the hierarchy, okay, like when we established that oxygen plant, it was because our hospital was very far away from Addis, about 100 kilometers from Addis. And there was no oxygen manufacturing in that vicinity, in that region. So we were transporting oxygen bottles from Addis all the way 100 kilometers, almost you can say every day. So that we sat down and said, why don't we have our own oxygen plant? And we started having our oxygen plant separately, not only for us, but also for other hospitals around there. And then happened to be that city called Adama. It's kind of industrial city. And everybody we didn't know, were looking for oxygen. Okay, this is 2017. 2018, we were already on expansion program. Okay, and we said, no, in this case, let's expand the oxygen plant. We expanded the oxygen plant, of course, working with the local commercial banks and so on. And then now, boom, comes 2019 with COVID. And the government was not ready with oxygen supplies. And there was only one or two in Addis that can be reliable in supplying that. Then the government approached us and they said, oh, okay, so now you've got all this capacity. In fact, we were using it only 50% of our capacity. Now because of COVID, boom, I mean, we couldn't supply all those questions. We couldn't entertain all those requirements. So the government helped us in one thing, so that we can get direct electrical power without any interruption, 24 hours. When you process oxygen, you have to work on the machine, tune it, heat it up, cooling it down for about 8 hours before producing 1 single liter of oxygen. And guess what? In Ethiopia, power interruption is very common. Okay? And then while you start your production, the second minute, boom, electric goes out. And you have to flood everything, you have to flush it out, and work on this one and that one. And then the hospital will be lined up, asking for the supply of oxygen. So what the government did was, they gave us a priority, just like a military camp. They get us a power direct from the dam to our plant, so that 24 hours, there will be no problem of electricity. This is one very good example that we partnered with. And then what we did was, in return, when the government was really in a very dire situation of having this oxygen, we gave them a priority to get our at least 50% of the daily production to government facilities, and the rest to the private hospital, and maybe 5 to 10% to the metal allergy companies. So in this way, we informally partnered with the public sector and part this problem.
That's quite interesting, because what I get from you is sometimes, and we always hear that innovation precedes policy and regulation. Maybe these are good examples. So the government was catching up and the need was there. And so it looks like you actually have a project that can then form a seed towards establishing a public-private partnership collaboration. Now, I realize we're almost out of time, but it's very, very unfair to not listen to the funders, the development partners, and what their views are as we wrap up around where do you think we should be putting our money as a country, because I know you're pulling out as funders. And as you're pulling out, where are your priority investment areas when it comes to things like partnerships? What are the things that, as development partners living, you think are interesting for the audience to get? Dr. Samora.
Yeah, thanks. Thanks so much, Frank. Very useful conversation we're having here. I think first, just to start by a confession as a development representative of the development partners, and I just want to say that, with a few exceptions, the development partners have been responsible for entrenching this dichotomy of private versus public. And this happened even when we supported both. I think some of the examples that Dr. Jerry was talking about were actually donor funded, World Bank receiving this support from donors, but we've sort of looked at them separately. We understand that there's a role for everybody, but we've not until I guess recently thought about how do we actually look at them as one ecosystem. So talking about this ecosystem approach that we've been having. And I think time has come now for things to change. Why? Because one, as you say, the funds are drying up for a lot of reasons. Countries in the region, if you're thinking about countries like Kenya, are maturing economically and therefore are not as attractive as they were before for development funding. And at the same time, I think it's time for us to wake up and realize that we've not been doing it the right way. So we need to actually start doing things differently. And why do we need to do things differently? It's because there's a lot of value in working together. We've seen this. Dr. Masibo has given very practical examples, and I always like this sort of very on-the-ground practical examples. So it's not something that's sort of built in there. It's saying, we have a facility, you have doctors, we have the facility, because everybody building a private hospital thinks we need to have a theater, we need to have this. Then you realize, but I can't afford the surgeons, right? And then the government thinks, every facility. And now we're having in Kenya, for instance, where there's a sense we have too many medical schools. We're producing quite a bit than we can absorb. So, you have specialists who've been trained being sent to places where they're like, but have nothing to do. We are 5 obstetricians working in a facility. So I have friends who tell me that they work 1 day a month or something, because, you go do your surgery for that month. And then you have other colleagues who'll be covering the other weeks, and you can get out. So, these are real things, real life examples that we are aware of. So starting to think, how do we do this? The question around, what is it that development partners can do? Proud, because the UK is at the forefront of this conversation. Some of the work that Dr. Masibo was talking about, again, trying to create this interface, this conversation where people have been working in the same space, but different roles, where the public sector are the prefects, and the private sector feel that these guys are just bureaucracy making our life difficult. But actually, when you bring people together and sit and see actually how do we do this together, how do we plan, what are some of the challenges that we are facing in this health space, and small examples. We've had sessions where different sub-national units. So these are the counties for those who understand the Kenyan governance structure, have been coming together and saying, actually, we've been able to do this. And when we talk together, we realize there's a lot that we can benefit from each other. He was talking about a lot of the solutions actually being just within the conversation and very little money being required. So for us, even as we think about value for money in a context of shrinking resources, saying, actually, instead of pumping so much money into an NGO to do something that's honest, and I know, Ian, you have a view on the question of sustainability. For us, is thinking sustainability is, if we pull out, will it be able to continue? And oftentimes the answer is no. This depends on a donor funding it. And for us, especially as a UK government, sustainability is not about, if we pull out, can another donor step in? because for us, that's actually just a continuation of the same problem. For us, it's saying if a donor pulls out, whether it's us or somebody else, it is actually going to happen. And so there are some of these questions that we've been having, and I think there's need for us to look going forward. So in one hand, for those of us who are in the development space, thinking about how do we support the creation of that interface, how do we facilitate some of those conversations, so that the resources that we have, as they're shrinking, they're still able to go a long way. And then a second bit, and I have my colleagues here who sort of looking at things from the investment perspective, is also looking at it from that private sector mindset of even that public health facility needs to start thinking about a sustainable business model. We should not be, we are taxes, so it's not about business. Quality is not the issue. If we start thinking about how do we make sure that we are providing quality, how do we make sure that we are minimizing our costs, so having some of that business mindset, then we start thinking about how do we move things forward. But also that a lot of the development partners are now thinking about moving towards more private sector-based approaches. So we're having investment firms and trying to bring in not just the government. Some of the governments have their own investment arms, and they're trying to bring that, but also looking at how they can then create space for institutions and investors from their countries to access the healthcare space in the region as a whole. So there's quite a bit that needs to happen there. Thanks.
Thank you very much. I think we've just run out of time, which is very sad because I was really, really getting excited with the direction of the conversation. But lucky for us, there's quite a lot of conversation that's still going to take place. So just recognizing a very important discussion that we've had in the panel. And, Noel is looking at me with a lot of anger. But, we will catch on in time, and I know exactly how. I would really like to just get 2 points or 2 questions from the audience, which, if the panel indulges me, I can actually help, put across or answer some of the things just to keep it short. Or if it's directed to a panelist, it can go. Is there any burning questions, or can we continue the conversations during the break? Are there any that are particularly burning? Dr. Gadango, I can see you at the back there. Mandela will give you a microphone. You have a question? Oh, you do actually? Okay, so I'm relaxed. The timekeeper has a question. That's normally a good sign.
Thank you. Thank you, Frank. My name is Mangutha Michael Gitangu. I'm an access leader in the healthcare space, working in the pharma industry last 5 years. My question is specific to the panelists. Investment cases, different priorities in different countries, some more urgent than others. Who has a bird's eye view on what is a priority, and then who coordinates all these investments, given that there are different interests across the public, across NGOs, across private sector? Who coordinates them? I think there are a few lessons from the different country experiences. Rwanda, case in point, I think there seems to be some light there in terms of coordinating the investments. Similarly in Ethiopia, but without pointing two fingers, who does what and who coordinates, who pulls the strings together? Thank you.
Noel? Yeah, as Mandela is finding his way to Noel, Michael, there's some good news for you. So Open Fences is an honest broker that's kind of playing that role on behalf of a lot of partners here, because the communication remains a challenge. But I don't intend to hijack the panelists responding to that. Let's listen to Noel's question.
Thank you so much for the conversation. My question is to the Ethiopian investor. I forget your name, I apologize. But it's fascinating to see how government came through using a multi-sectoral approach to actually boost healthcare by pulling power to your facility. So for me, it's to maybe Dr. Gitau and Samora, as you think about PPPs, are you thinking about a multi-sectoral approach? So water, agriculture, even security is important. And looking at that in terms of enhancing the PPP so that health is optimized.
Thank you very much, Noel. So I didn't see any other hands shooting up. Yeah, so I think Noel's was more of a reflection But if any of you wants to just address that, because sometimes we think about PPPs in terms of private health sector and public health sector, but really it's possible that it's between a private health sector and a public utilities company, isn't it? So there's that idea around multi-sectorality and the importance of thinking very, very broadly. And Michael's question was just around, so who coordinates all these efforts, across the different countries? So I don't know whether anybody wants to just close the session. So Dr. Kebiende has been kind enough to just to answer that question on behalf of the panelists. Dr. Ali, please go ahead.
Yeah, thank you. Let me come in here. Although I do not have a very good, PPP example in South Sudan to give, but I have mentioned and I alluded to a joint investment case during my interjection, and I actually give an example between the government and the financing agencies and the NGOs for that matter. And I will still go back to that example. We all have, the investment towards, fighting the epidemics, whether it is HIV, malaria, or TB in our various countries, whereby we have entered into this partnership with the Global Fund that gives us the money. And at the same time, there is also a co-financing obligation, which to me is not just Global Fund investing. It's actually a joint investment to fight the three epidemics. And in this case, it's now second or third year that, a huge or private sector involvement has become a serious agenda. And in all the countries, it's now coming up that the real private sector needs to be involved, because some of these interventions can best be performed by the private sector. Let me give an example. The distribution of the mosquito nets as an intervention, as a vector control intervention, basically it's a logistical function. It doesn't need to have an international organization or an organization whereby you do a full funding that includes, an annual budget with all the HR, with all the overhead from here all the way to Washington, to New York, and all those places. You just give it to a private sector, agree on a performance base, and they will just do the job to the best and will be the most efficient, intervention. Coming to the coordination of such investment, joint investment, the Global Fund investment with the countries is much more developed. Every country has got a coordination and oversight body that is there to oversee that investment, which is also more independent. It's not actually to safeguard against all the other, conflicts that might be here and there. So that is just an example that I can give. Thank you.
Yeah, so Michael, I think that has been well explained. The Global Fund mechanism is quite unique. The coordinating mechanism is multi-sectoral and public and private sector with very strong government leadership. So I think that has always served as a fairly good coordination mechanism. I guess the more complicated question is, how do you identify which are the investment cases if you're an investor and where to find them? And I think that's the next level of this conversation. So with that, yes. Sorry, Dr. Njeri, you had to say something? Sorry, I missed that.
So Noel,
the only lady being missed. It's a travesty. So please go ahead.
Thank you. Noel, yes, there is a multi-sectoral approach to working with the private sector. And I'll give one very short example. So we know one of the pillars of our healthcare system is access to good quality health products and technologies. Kenya has a very vibrant pharma manufacturing sector. This is purely private sector. We're looking at UHC. We're looking at having more affordable, high quality medicines, which our pharma manufacturing firms actually have, especially those that are WHO pre-qualified. So these pharma manufacturing firms cannot, for example, do profitable business if they are not enabled. Government is an enabler. So one, through policies and regulations, through tariffs, through taxes, through subsidies for electricity, to be able to, for example, import APIs at a much lower rate or tax-free subsidy. And again, also government supporting them. So one of the things that government has done, especially to support the pharma industry, is the Buy Kenya, Build Kenya initiative. So 40% of all government procurement, including parastatals, is supposed to come from local manufacturers. And this goes across all sectors. Manufacturers in Kenya are all private sector, in all sectors. That's a very huge, actually, example of government working across all sectors. And so for our pharma manufacturers, we have a generic list of all medicines, products and technologies produced in Kenya that government should actually procure from. And these are actually being tracked in terms of every 6 months. Agencies to actually give evidence of how much of their procurement has come from the private sector. So that's just one example. And you can imagine and this also applies to entities like KEMSA. KEMSA supplies to our public facilities. It also applies to meds that supply POs and other smaller private health facilities. And this ideally should bring down the cost of care. This is within the broader context of a lot of regulatory reforms that we are working on bringing down the cost of medicines in Kenya to ensure that healthcare is affordable.
Yeah, no, thank you very much, Dr. Njeri. That was well worth the wait. So the conversations continue. I think we are all connected. So please feel free through me, either through me or through Anastasia or the other organizers, to reach any of them for these conversations to continue. We've had very, very rich and detailed conversations from the ground. Dr. Masibo has told us about opportunities for partnering, even when money does not exchange hands. You know, that is extremely important. And Dr. Njeri has told us about the policy levels and how they enable these types of partnerships to happen and what is actually happening in practice, including multi-sectorality. Dr. Samora has told us about the development financing. Development assistance for health is going down. Yeah, it's going down increasingly. And COVID actually showed us that when things get bad, every country looks out for its own interests. So it's time as a region, East Africa started looking at its own strengths and building on its own capabilities and making sure that it's investing in creating ecosystems, better partnerships, to take place. And he gave an example of some of the work that FCD have been doing with Open Fences, for example, creating these types of partnerships. David gave a very interesting live example of how not to let a good pandemic go to waste. So it's one of those things where you are doing public good, but at the same time you're trying to do good business, and then the opportunity actually comes later on, and you actually realize that this is a case of a tail wagging the dog. So the partnership will actually follow something that you're already doing. And if you are to ask me, David, it's an opportunity for you to shape the conversations around setting up a public-private partnership framework for healthcare around what you did. So you create lessons that then feed into that. Ian told us the East African examples and the value of looking and learning across different countries. Look at some of the contentious projects like the Queen Mamohato Hospital in Lesotho. What are the bad things? What are the good things? What can you transfer? These countries are also quite different. Kenya is different from Uganda. It's different from South Sudan. We can learn from each other, but it's also important to contextualize what applies in different countries. And of course, Dr. Kediende wrapped up by basically telling us about his role coordinating this in a fairly new country, and what the kind of opportunities are for a country that's coming up quite aggressively, coming up quite fast, but also willing to engage, although the structures are not there, admitting that the private sector is quite small and the market is still a bit uncertain, and thinking about how can you de-risk such markets to enable the private sector to work well. And we talked about impact, investment and blended financing instruments and other opportunities that could actually come and catapult the private sector to a level where it can support the public sector. So please join me in giving a hearty clap to the panelists, and thank you all very much for a very rich discussion. Have a good afternoon.
Another round of applause, ladies and gentlemen. So at this point, I'd like to go into investments in health, and I'd like to During our session partner, Varian Medical System, I'd like to call upon Ansu Dukure, the Managing Director for Varian, to give us a few remarks.
Good morning. So my name is Ansu Dukure. I'm the Managing Director for Varian Medical Systems. Some of you may wonder who